because usually I ask people, how long do you think the gap is
Yeah.
between serious symptoms and diagnosis? You want to make a guess? Decades. Exactly.
Yeah.
It's 7 to 10 years. And
Yeah.
when patients finally get diagnosed, they get ticked
Yeah.
because they realize I could have had some meds, I could have had an awareness of the environment and how it triggers my symptoms. I wouldn't have to hide behind a misdiagnosis of it's your heart, it's your age.
Welcome to the Expand podcast, where we unlock the secrets of respiratory health for healthcare professionals. Join leading experts as we dive into chronic lung diseases and expand your practice.
I'd like to welcome Dr. Wright from the COPD Foundation from United States. Dr. Wright, it's okay if we talk to each other with our first name. I'm Jean, you're Jean, then...
This is unique for me to have the same name as somebody across the microphone. So this is going to be fun.
It's quite of interesting because obviously when I go in the state, they call me Gene.
Yes.
And they probably found that quite unusual for a man to have that name. Dr. Gene Wright received her medical degree from Wayne State University, a master in business administration from Emory School of Business. She's been appointed CEO of the COPD Foundation in December 2022. She joined the COPD Foundation several years ago to follow her passion for driving change in the delivery of care to improve the health care for over 30 million Americans with COPD and serve on the COPD Foundation board of the director as secretary. Additionally, she served on the executive committee, advocacy and public policy committee and strategic planning committee, and chaired the board governance committee. Her accomplishments include a lot: leading strategic partnership in human-centered design and business model innovation that were focused on accelerating healthcare transformation. She's been recognized as one of the top 30 chief innovation officer in America and nominated for the 25 most powerful women in health IT in the United States. Then let's start about this interview and discussion we're going to have on the respiratory disease, but primarily a COPD. And what I'd like first to hear from you, tell us about your trajectory that had made you interested in the respiratory and COPD.
I have an unusual path into this disease because if any of the listeners would check my LinkedIn or look up a YouTube video, I'm a pediatric anesthesiologist and intensivist,
Wow.
right? And most of my patients have never had COPD, right? So you're wondering, did you take the wrong turn in the hallway? How did you get there? Well, my area of research has always been in health services research, so the delivery of healthcare. And as you know, I went to business school halfway through my career, which was really enlightening because I realized so many other industries understood delivery of services probably better than we do in healthcare. So fast forward, it's 2010. I end up with a multi-million-dollar grant from the government looking at how we could use clinical informatics to impact chronic disease. So I was working with a nurse, and she said to me, Gene, I think we ought to focus on COPD. Well, I hardly knew the disease. In fact, I often joke, I didn't even know how to spell it. And I said, well, what is that? Because back when I was in med school, we either called it chronic bronchitis or emphysema. We had, if you remember the Netter books, right? The pink puffers and the blue floaters, right? Those pictures stuck in our mind. But I said, Deb, I don't think we should focus on that. And she said, no, think about it for a second. We are moving in the United States into an area where there's going to be penalties on readmissions. And COPD as an illness has a high likelihood of readmittance. And in fact, in our own county in North Carolina, some of our patients were facing 30% readmission rate. 30% 30-day readmission rate. So it's bad enough to be in a hospital, but to come back like a yo-yo within 30 days and you realize I didn't like the green jello the first time, I'm not going to like it 30 days later. And I said, but Deb, what about heart disease? What about diabetes? And she said, the cardiologists are all over heart disease, and they're going to keep you at arm's length. This is a chance to work off screen with a big population. And so I came back and I said, then let's do diabetes. She said, Gene, internists, endocrinologists, they think they have it. You want to go to the blue ocean. And that book had come out as a business strategy, Blue Ocean Strategy. She said, you don't want to be where the sharks have already made the water bloody. You want to go where it's calm, where nobody thinks you can make a difference. And I said, well, you're kind of convincing me about that, but how big is this problem? And so we started doing some research and found out probably 30 million people in the United States. We're going to say probably, and we're going to get back to that later. Is that really the right number? Because it seems like only 15 million carry a diagnosis, at least when you look at claims data or their EMR. So she said it's probably 30 million. And when you look globally, it's at least 300 million. Now she had my attention because, as we in statistics say, the N is there, right? You got to have a big enough.
With your MBA, I'm pretty sure that you said to yourself, we have a business here.
We have a business case, and let's talk marketing. We have an addressable market, right? And we have a big enough N that if we begin to bend the curve, right, we're going to be able to see it. So, John, in my past, I did a lot of research in ECMO, extracorporeal membrane oxygenation.
From ICU,
right? We might treat 12 patients a year. Suddenly, when I sat back, and I was part of Atrium Health, a big system in the South, when we looked at the state of North Carolina, we said, wait a minute, 1 million people in North Carolina, if it's 8% of the population, here's how many people we think could be. Let's pull our EMR records. Let's see how many are diagnosed. And it was a fraction. We had not even identified, even the tip of the iceberg. So now she had me hooked. I thought, we have a hidden epidemic. We have patients who have a terrible disease, and we'll get into that also later, because if you've been touched either with the disease yourself or have a family member,
absolutely,
I mean, it's an ugly way to leave life, right? They struggle, they're anxious, they're short of breath, and there's not a lot of great resources for it. And then she got me into it because her own mom had died from it. And so she had a personal story. Now, we're going to fast forward. Later on, as I got deeper into this, I got my genes tested, right? Here's one more use of the word gene today, right? And found out I'm an alpha 1. I'm an alpha 1 carrier. Absolutely. So I have the genetic form. In fact, I've since gone on to contact my family members to see where else it is. So I came through an unusual route. I came through the lens of a health services researcher. I'm not an epidemiologist like you, but big numbers get my attention. And then I would say I was a bit of a doubting Thomas, because if there's anybody here who has COPD, I'm going to sound a little judgy, but I, like many people, thought this is a smoker's disease. These people don't want to be found or changed. I was just talking to a young researcher a few minutes before this podcast started, and we talked about, do these people really want to be found? Maybe they're missing, and for a reason. And I also thought they were a bit stodgy, curmudgeon. I don't know what the right Canadian analogy would be for that, but they've gotten to this place. Many times their families have kind of stood back from them and thought, you got yourself into this. Somebody that was working on my team said, Gene, I hate to say this to you, but I actually don't care about people with COPD.
Wow.
I had never heard anyone be quite that blatant about it. And we'll get to some of the reasons why it's so difficult to find these people. Yeah. So long answer, lots of little turns in the road, but health services researcher looking for a big population. And then lastly, I'd say, can you move the needle? Because there's some healthcare conditions we know I can't do anything. And so I felt the same thing. And so we did a pilot, and it was before we had the EMR in place. It's before we had HIEs and all these other TLAs, 3-letter acronyms, right, that explain healthcare electronic records. And so I was going in using some raw data sets, and I'll I'll jump you to the end of the story. We got from a 30% readmission rate to 6%.
Yeah.
Wow. That now I'm going to throw some Southern phrases at you as well. That dog will hunt, right? If you can move the needle like that, then that told me this is a movable, manageable population. And when we do this, their quality of life goes up. They get to go to their daughter's graduation.
Absolutely.
They get to go to the fifth grade band concert. They get to be out with people again. And we change that trajectory. We may not be able to add years and years to their life yet, but we can at least make the quality of life they have so much more enjoyable. So how's that for the first question?
That's good, Gene. You've been touching some very important point. But first of all, at some point in time, you saw the light at the end of the tunnel. That person convinced you, and lucky we are, okay, that she convinced you that you're on board now. There is a lot of issue that relate to awareness, and I often say to my patient, okay, that COPD, it's like the Alzheimer of the lung. Okay, therefore, people are really adapting, they're hiding, therefore till the point that they're relatively sick or they get to the hospital, and then when they are in the hospital now, they get obviously our attention because there is a problem that we have, okay, to take care because of the cost. But now we're just starting to see
and you're probably a ringer, because usually I ask people, how long do you think the gap is between serious symptoms and diagnosis? And you probably know the answer. You want to make a guess?
Oh, it's decades.
Decades, exactly. It's 7 to 10 years. And when patients finally get diagnosed, they get ticked because they realize, I could have had this diagnosis. I could have had some meds. I could have had an awareness of the environment and how it triggers my symptoms. I wouldn't have to hide behind a misdiagnosis of it's your heart, it's your age, it's your arthritis. And they're like, no, we can't breathe, right? It's decades. And I love your analogy. In fact, I wrote it down about it's the Alzheimer's of the lung. Unfortunately, I have a sister who has Alzheimer's, and the diagnosis was obvious to me for a while, but not so obvious to her husband and children. One, because none of us really want to admit that. That's also one.
Exactly. There's a lot of deny.
Yeah.
People, obviously, the best adaptation when you're out of breath, it's stop doing what make you out of breath. And that people reduce their activity, and until you get to the point that it impact on your activity of daily living, or you have severe exacerbation requiring hospital admission. But what do you think you've addressed a bit of that, okay? What you want to change, but what has changed and what has improved since when you start? Okay?
All right, I'm going to start on the cynical negative side. There hasn't been a new drug or drug class in the last 11 years.
Yeah.
Can you imagine that with cancer or heart disease? Can you imagine how the patients and the caregivers would storm, in our situation, Capitol Hill, right? And get their congressmen and their legislators to change the laws about it or to fund the NIH to develop these drugs? Hasn't happened. In fact, about 6 months ago, our National Institutes of Health said, we're taking a pause on COPD. Okay, this is in the shadow of COVID. If anything should have electrified the world to understand the importance of the lung, it should have been COVID.
Absolutely.
And we have the NIH telling us. Now, I won't ask you all the trick questions I often ask students and residents in that, but it's the third most common chronic illness. It's the third leading cause of death. It's the third driver of readmissions. But in terms of NIH priority and funding, it is, drumroll please, 170th. 170 or lower. It was 165 at one point. I think we actually had some slippage.
We're not doing better, unfortunately, in Canada, and that's kind of being generalized across the world. Why is that? Why is that?
Well, one of my favorite things to talk about is this invisible epidemic. In
Yeah,
fact, one of my team members right now in the foundation says, Gene,
I
we need
agree
to
with
read
you.
a book. We need to write a book called In Defense of the Smoker. She said, not the defense of smoking, because we all know that that's a terrible trigger for lung disease, heart disease, whatever. But she said the smoker was duped, especially the smoker in the US in the 60s and 70s. They were led into something. It was socially acceptable. There were ads on television that says your doctor prefers that you smoke this kind of cigarette. And then there was that nasty hook of the addictive qualities of nicotine. And then our government hid it, right? And so
Absolutely.
we want to come across now as a foundation that says, I get you, right?
Yeah.
Like most
And then
teenagers,
we blame the smoke. We blame the smoker.
right.
That's
You
it.
know, I tried it. Gratefully, somebody talked me out of it early on. I know now when my kids listen to this, they're going to go, oh, mom, no, please don't tell us. Right. But gratefully, I didn't get addicted, right? Because I stopped early enough. But we need to defend the smoker and explain to them what happened to them and how they were in many ways, a victim of this, so that the stigma and shame
Yeah.
dissipates. I don't know what it's like in Canada, but one of the reasons we have a hard time getting this on the radar is the stigma and shame.
It is the same.
Yeah.
People feel ashamed.
Hmm.
There are a lot of people that make a patient feel ashamed.
Hmm.
We don't do that with any other health habit or even addiction
Right.
that would cause chronic disease. But we do that all the time, unfortunately,
Right.
in the patient that are smoker. We've started to see other cause than smoking.
Right.
Pollution is probably going to build in the next decades, okay, and becoming, even in the developed country, a
Absolutely.
cause of, okay, COPD as well.
Yeah, I'm sorry that pollution is moving up, but I'm sort of glad because it takes some of the spotlight across from
Yeah,
smoking. I just wrote our team this morning, and depending on when you listen to this, may or may no longer be relevant. But we've been watching the wildfires in Hawaii. Who
yeah,
would have thought, right? Of all the places, doesn't it rain there every day? Well, today on our radio stations, they're talking about now that the fire's dissipated, there's still toxic chemicals. I
yeah,
often say, if you can smell something, say something, right? Because if you could, unless it's a steak on the grill, or as the Aussies would say, something on the Barbie. But unless it's that, and maybe even that's probably dangerous if it's charcoal or whatever underneath it. If you can smell something, say something. So if there's a bright spot in pollution, it's being able to now turn people's attention to this mindset of you can get COPD.
yeah,
We're just launching a campaign at some of our minor league baseball stadiums. And we're saying, look, in the United States, 30 million people a year come to a minor league baseball game. So it's a real popular local, it's price sensitive. People can afford to go to it. They eat the popcorn, what have you, and they root for the whole home team. There's 30 million people with COPD. So that at least gives them a number
or what
to
it, yeah, exactly.
yeah,
What you
to
would need to fill and how many times. No, you are right. I'm kind of feeling the same way than you. I'm not happy in any way of seeing what is going on with the pollution, the wildfire. Terrible what arrived in Laina, okay, in Maui, where we
right,
have a huge problem across Canada since June.
right.
But at the end of the day, it's kind of now giving that attention that it's taking the problem away from smoking. We have more and more study.
Yeah. We
You've
know
done
we
some
know
of that
firefighters
investigation.
are at risk. Everybody
Yeah,
knows the story of 9/11, and I often say if you were a firefighter and you were fortunate enough to both run in the building and run out, because we know we lost
yeah,
hundreds
yeah, lots, yeah,
of wonderful heroes. But if you were able to get out, you came out with COPD,
yeah,
right? And so
absolutely.
our firefighters, we know our veterans, gratefully there's some news people like John Stewart who are making the public aware and using that voice to say this is a risk, right? This could be you. And so One of our current campaigns that we just launched is 1 in 8. 1 in 8. And so if you're at a stadium, count 1 in 8 and see, who might
How
have
many people that
COPD.
may, yes.
Yeah, in fact, I'm kind of preaching to myself right now. I actually just got goosebumps from that because I don't think Joe on the street knows that, right? They know about heart disease. They know that they might be at risk for, the big one. They even know the widowmaker and some of the stuff, but they don't know this disease. I was talking to a public health advocate the other day, and she said, Gene, what's the biggest problem when you go to call on Congress people or get the word known? I said, I spend 3/4 of the call explaining the
Yeah, what it
disease.
is.
Now, Jean, if you went in to explain breast cancer and why you wanted more funding, do you have to explain breast cancer
Yeah.
to your, your
No,
legislators, to your voters? No. Do you have to explain even osteoarthritis or maybe even something much rarer, like there's been great headway made in cystic fibrosis. Somebody asked me the other day, is cystic fibrosis sort of the pediatric version of COPD? And I said, well, in many ways, it is. That's 100% genetic. We know that ours is more multifactorial. It could be genetic, like alpha 1. It could be some of the great genes that are being studied in the COPD gene project. But it's like 65,000 kids in the United States. We're talking about 30 million people.
yeah,
We're
no,
talking
because
about,
they're a kid, we know that. Because they're a kid, that make a difference. Gene, let me ask you, because you've been referring in many times, and that's how I want to hear, and I'm sure people want to hear about that. What is the COPD Foundation and the COPD 360 Social Committee platform that we hear more about these initiatives?
I'm glad you're hearing about this. We pride ourselves in being a patient-focused organization, and I can't say that's all because of me. It's like if you can see the future clearly, it's because you stand on the shoulders of others. Our founder, John Walsh, was a
Yeah.
patient, and he fought passionately about it. We have patient steering committees. We try to bring a patient into the start of every project, not let's design this and then add Mary Lou at the end so we can say we have a patient on it, kind of wink, wink. But no, let's start with, in fact, we have a project called Patient Inspired Validated Outcome Tools. Pivot. What it means is let's start with the outcome metrics that really matter to patients. Most patients, get ready, here's a Southern phrase, don't give a hoot in a high wind about their FEV1, right? They don't. They want to know, can I go through the grocery store and not have to take a canister of oxygen with me? Can I go on a flight with my concentrator and not have to worry about liquid oxygen? We had a board meeting a few months ago in Denver, the Mile High City. We have patients on our board. Our patients struggled with that. So, you can look at it from a variety of different sides, and we want to keep the patient at the center. So you asked about 360 Social. Again, those legends before me, they wanted a platform, not just a Facebook club, and those are good, or not just a chat, but a place where patients, caregivers, providers, industry could meet together. So we have
Okay.
about 56,000 people on that platform. We have it moderated. We know sometimes people ask very specific medical information, so we try to get them off of that platform into the care that they really need. We also have the patient powered research network, so where patients say, I want to volunteer, I want to share
Wow.
my data in a way that we can help others. We have that for COPD. We have the bronchiectasis registry. When I first came on the board, I didn't understand the importance of bronchiectasis. I didn't understand that bronchiectasis is a narrowing of those larger airways. Doesn't seem to have as much of the emphysema component. But then many of those patients also have terrible bacterial infections that are almost
Absolutely.
impossible,
A lot of exacerbation. Yeah.
to clear. And so I've been kidding our key opinion leaders. I said, I think I'm ready for the boards. You guys have gotten me educated enough. But back to your question, we know social support is important. In fact, back to my early days, I looked at things like we have the Joint Commission who has disease specific certification. They have 200 things that you should do if you're going to provide care as a system. I thought that one's not going to work. Hospitals are too busy. They're too resource constrained. And I got to the point where I thought, if you can screen patients, if you're going to follow evidence-based guidelines, if you're going to put them on the right meds, if you're going to offer pulmonary rehab, and then lastly, if you're going to offer them a support system, those 5 things, I can guarantee you're going to make a difference in the quality of life for patients. Now, we're kind of strapped.
We do,
because
you're
in the
right.
US,
We do have the data on that. But let me take that and bring you somewhere else where it's quite important. Because we know about the disease. There's still a lot of things we don't know, but it's about doing with what we know. And we don't
Right.
do with
Right.
what we know. We know that there are treatment, pharmacology and non-pharmacology, that can help the patient improve in terms of their symptoms, exercise capacity, reduce the risk of exacerbation, and
Right.
so on.
Right.
But things don't happen as we would like compared to other chronic disease. Well, what about your expertise in predictive analytic and AI? What are is it the place where we can make a difference? Because the
Right.
doctors are so busy, they have so much now, it's the family doctor in particular, to do that. How can we
Oh
help
my,
them?
you've got so many things for me to riff off of right there. I used to tell our system chief medical officer, if you would allow me to create a division to just deploy what we already know, not just the COPD, this is true of all disease.
A lot of, yeah.
Right? We don't have to learn anything new, right? So like when we started getting deep into COPD and we started pulling medical records, we found people who have a diagnosis on their chart and they've never had a pulmonary function test. Okay, you know, if you're not a respiratory physician, maybe that doesn't really register with you, but here's another country phrase, let's shuck it down to the cob. For cardiologists, would you diagnose somebody with a heart attack without an EKG? No way. Would you do
Absolutely not.
diabetes without hemoglobin A1C? Am I beginning to preach
Absolutely
now?
not.
No. And so we're doing pulmonary disease without pulmonary function tests. I'm at the point right now, I would be happy if people in the doctor's office, and there's probably OSHA laws about why you can't do it, but at least hold a birthday candle at arm's length. If you could blow it out, you probably got a decent FEV1, right? Then I could take you off the list and just really work with the people who couldn't blow the candle.
Blow the flame, yeah.
You know, but we need pulmonary function tests. Many offices have them and they're dusty and they're sitting in the back. Now, you and I both know it's easier to do an EKG because it's not effort dependent. Right now, our pulmonary function tests need somebody saying, take a deep breath, hold it, and all the way out. Yeah. And so we need somebody there, or we need somebody virtually there, right?
But technology should help there.
Absolutely. You know, I can't say her name because she's in the background right now, but there's somebody that's listening all the time that probably can tell by the sound of my voice on a daily basis. I'm working with a company that's looking at how sound in a behavioral health setting tells you whether the therapeutic intervention is happening between the counselor and the patient, not from the dialogue, but from the pace. I mean, I think our audience could tell you and I really like talking about this. Our energy's high, our catecholamines are high. If they're watching, they're seeing my hands are moving. You're much more reserved than I am. You know, there must be some Italian in me somewhere because my hands are all over the.
We talk more with our hands sometimes than,
Right. But if we could do what we know to do, like if we knew, here's the goal criteria, here's 3-drug therapy, here's pulmonary rehab, we could make a huge difference even before turning on the AI. Now, I don't know about you, but when I first heard about electronic medical records, I got excited, right?
Yeah.
I thought, this is going to be like the GPS, right? It's going to alert me and say, Gene, look out. This patient has an elevated creatinine. Don't put a amikacin drug on board, right? We didn't get that. We got a charting document. I'm trying not to use bad words there. We got a black hole of charting and billing software, but we didn't get intelligent software that directs us. Now, fast forward, I think we're on the cusp of that. We're still a little slow. I've got a project right now running with some collaborators at Wake Forest, so about an hour north of us, where we're looking and saying, can we find the missing million? Because in reality, we can see some patients that look like this, and I'm holding up my hand, and some that look almost exactly like it. And for all the world, they look, smell, even without asking the word smoking history, like COPD. Why
Yeah.
couldn't we call them and say, your doctor's really trying to effectively use your medical record to help you? And we're going to do a lung history on you, and we're going to do some lung health tests. You don't have to bring out the scary word, COPD or things that they don't understand. We talk about heart health and brain health and kidney
Yeah.
health. Let's just make that common. So predictive analytics is going to help a lot, but we're not there yet. It's probably that 10-year gap again of
Yeah,
we
probably I
have it
agree.
there. I mean, I
Yeah.
use a device in my car right now, my cell phone, that tells me don't drive this road because, there's a car stopped ahead, or don't drive this way because the road's blocked. Why can't
But
I get that
I
in my
agree with you, and I
EMR?
like very much when you were talking about EMR, where it's still very rudimentary, and EMR has been used more now for that. I can read the writing of a doctor that I have the hard time to do. Everyone can, that I can have a report, that I can have data, that I can do billing,
Yes,
more than integrating the information and flagging a problem, or learning from that, oh, this patient should be on this treatment and is not on this treatment. Then that
right,
part is
right,
still not integrated, okay, in the
right.
machine.
Yeah. I'm going to ask you a question if that's
Yeah.
okay. Do you think healthcare providers are going to crack through this invisible epidemic, or do you think it's going to come from the media, from the government, from patient to patient? Where do you see hope?
I don't see hope in the government. Let's start by where I don't see hope.
Right.
Because a good example in the state, since I've been at the ATS, and it's been a few years, looking at the color of my hair and my mustache, more than 30 years. We didn't even have the assembly of pulmonary rehab. I was in the assembly of a nursing, in fact, and
Right.
they've been going to the Senate in the state for years and years and years after years, and it sounds like it's redundant, and we still don't have it. Then I don't
Right.
believe it's going to come from the top. It's going to come from the bottom, okay, the patient, okay, and obviously group like your group,
Mhm.
foundation, association. I think we have to work more together, I will say, Gene.
Yes.
The group of patients have to work more with association of professional, and or even like gold at an international level, okay, and local, that and this is something that we will make a difference. Sure, look at it just for a minute, and I'm going to let you taking over, since I'm the one who should be asking the question.
No, I
But
like this.
if there was no problem with the hospitalization, because that's what had triggered all the interest on exacerbation. We were
Right.
not talking of exacerbation that much 30 years ago, okay? But there was no treatment anyway. But when it became a problem that had an impact on the healthcare system and a cost in terms of the burden of cost, then people got interested, maybe more into the cost
Right.
than they got interested into the patient. But at least
Amen.
it started
Amen.
something.
Preach it. Preach it. Yep. You're right on that. And especially when COVID hit, when the capacity of the hospitals were over, full and overflowing, it brought attention to that. Like, oh, we can't bring in our elective hip and knee patients, which drives our revenue. Let's get these really expensive COPD patients, heart failure patients
Yeah.
in some other form of care. It's been a couple of months since I looked at it, but I think 20% of people say that they got their diagnosis of COPD during an admission or an exacerbation, right? So it's not like you know, I often say, did you see it coming? No, they didn't see it coming, right? And they
No, no,
got in
no,
the
no,
hospital and
absolutely not.
surprise them. And then you think about trying to educate a patient
Yeah,
about
yeah.
that. Right. Yeah,
And
I
many of
am.
them are missed even there. You wouldn't miss a heart attack from saying, oh, this patient has a coronary artery disease. I often say, the patient come with a chest pain, found to be to have an MI, and then he's going to get to the coronary care unit, and he's going to leave the hospital with a bunch of medication and everything he needs in prevention of that it will not happen again. COPD
Right.
patient, they come in, they're in the
Right.
corridor. They don't even make sometimes the diagnosis. The patient, if he can be kicked out quickly of the hospital, he's going to be kicked out. If he's admitted on the floor, he's going to leave the hospital mixed up with I don't know which medication
Right.
inhaler. Sometimes
Right.
they're all mixed up. Okay, and he's going, and someone else is going to take care of the patient. That's
Right.
kind of the typical difference between a patient
Don't
admitted
get
with
me
an
started. Like,
coronary artery disease.
why do we have them on nebulizers in the hospital, and then 2 hours before they go home, we
They,
try to teach them how to use a handheld device? They're worried about if their daughter-in-law is going to, make it to the hospital. Where's the parking lot? And they still feel terrible, right? They don't feel
yeah,
great when
yeah.
they leave. They still feel terrible when they go
Absolutely, and
home.
we know we can make the difference. You
Yeah.
said that before, and we have with rehab, with the right treatment, pharmacology, and so on. Okay, let me ask you a question.
Oh, wait,
Yeah,
wait, wait.
go ahead. Yeah,
Earlier you asked me, what was I hopeful about? I do think there's a new class of drugs coming, biologics, that's understanding this T2 pathway. I think that's exciting. Frankly, if people would do pulmonary rehab, right? Whether
yeah,
in person or virtual. It was funny. I was talking to some doctors in my backyard, and I've been a big proponent of virtual pulmonary rehab. One, because about 10 years ago, we had this game at home called Connect, and you put it on, and it had a sensor like your camera, and you would,
it started
exercise
to
and play
dance.
games. And
Oh
I
yeah,
kept thinking, we could do this for pulmonary rehab. In fact, my innovation group started working with models of that. If we could get people on 3 drug therapy, get them to quit smoking, get their immunizations on an annual basis,
yeah,
right?
absolutely,
When possible, stay away from other people that might be sick, right? And then do pulmonary rehab. Their quality of life goes up. We don't have to invent anything else. Now, we still should, but those factors alone raise somebody's quality of life. And the
absolutely.
public doesn't know that yet. They don't know that
But
that's
Gene, it has to start in the curriculum of our new doctor. And I have to, I
right,
keep teaching because I have a COPD clinic, and I keep teaching my resident. And the resident often say, "Oh, Dr. Borbo, I forgot to ask about vaccine. Oh, I keep forgetting ask about vaccine. Oh, I forgot to ask about this." Then, well, if that patient was a diabetic patient, or that patient had the coronary artery disease, that would be systematically exactly.
right,
I'll take a capsule of
right,
what you just said before. That's exactly the right drug. Very often more than one that we do in cardiology.
right,
Smoking cessation or avoiding exposure in the
right,
environment, vaccine, and it's adding up now. It's not only the flu vaccine and so on. Okay,
right,
then rehab that people learn earlier on about
right,
managing their disease, do exercise, change their health habit, and we work on that, and we give importance on all of that. Like, we measure the blood pressure, we ask the patient, how is it going with your physical activity, what are you doing? Because if as a doctor you don't ask that, if
right,
you ask that, the patient started to see that, oh, the doctor is giving importance to that, therefore, okay, that become to
right.
to change over time. And then
Exactly.
research, we've been talking about research, that's my next question, because
Uh-oh.
it's about using what we know, and we're not even using what we know, but the research still have to continue, and we have
Right.
a very hard time to get funding. What is the problem with funding in COPD? Why is that?
Um, I think, it gets back to there's some people that could make a decision that don't care,
Yeah,
that don't care. And so this is one area. In fact, every fall we call on our elected officials on behalf of the COPD Foundation. So I was calling on mine, and they said, Gene, nobody crosses our threshold and talks to us about this disease. where are you? Where's your patients? We don't have a activated grassroots effort. Now, the COPD
Mm.
Foundation is really getting intentional about it. I mentioned this thing about the ballparks and 30 million people. We've just launched a program at the minor league ballparks where we filmed patients playing the harmonica. When patients play the harmonica, it's called Harmonicas for Health. It's actually therapeutic because it's personally
Long
breathing,
expire, they expire for long, and then
right? And
empty
so
their lung.
you can see
A
it on
nice
our
analogy.
website.
Yeah.
And then we film them doing the Star Spangled Banner and Take Me Out to the Ball Game and a bunch of things like that. The patients had a blast, and Southern phrase, bless their heart. One lady came 2 hours early just so she could be in the thing. Some brought their concentrators with them. It mattered that much to them. So we're thinking, I asked you the trick question before. Is it going to come from healthcare? Is it going to come from the government? We're not waiting on them. We're trying to get
Yeah.
right to the public, right? Let us do an end run and get right to the public. If you think about, the ED meds, the Viagra meds, Bob Dole, he went right to the public, right, to talk to
Absolutely.
them. And so I think we've got to do some of that so patients begin to know, oh, it's 1 in 8, right? That comes
Yeah.
through in one of the things that we show at those places.
And
But
it's not a dirty disease. It's not something that you should blame yourself for. It
no,
is something that you should start learning, that there is a way to recognize and there is a way that can do something for it. And you're
yeah,
entitled to ask, like a diabetes, like a patient that have obesity, like you're entitled to ask that, okay, the healthcare system and
right.
your doctor is there to help you in that sense.
Yeah. Right now, to get a new drug approved through our FDA, we have what many of us consider antiquated endpoints like hospital admission,
Yeah, yeah.
readmission, death. Um, and patients are saying that's all well and good, but that's not what's really important to me. I want to, and it's fill in the blank. I want to be able to go visit my kids. I want
It's
to
good. Yeah.
do that trip I've saved up for 30 years. I want to do those sorts of things. Not long ago, I was in physical therapy myself or something, and about 4 weeks into it, they finally asked me my goals. And I said, I want to run. And they kind of looked at me like, you don't look like a runner. You're too old to run. I said, I don't want to run a marathon. I have
Wow.
a dog that when I take it outside, if it gets off leash, I need to be able to run fast enough, far enough to catch this dog, right? I don't
Yeah,
need to run the
absolutely.
Boston Marathon. But right now, I'm not able to kind of sprint and, have that kind of balance that I need. I knew what I wanted as a patient, but nobody asked me till I was well into my treatment. We need to, as physicians, healthcare providers, PAs, nurse practitioners, we ought to be asking patients,
Yeah.
what do you want? How do you feel? Are you functioning at the level that you really, really want to?
Thank you very much for giving a voice to the patient, because that's you just said, and I completely agree with you. That's the most important. How can people reach you, Gene? And again, that people can start going to your website, your
Yeah.
platform, and visiting, and then
Our
having more
website
people.
has a boatload of terrific resources, again, made by our team, our multidisciplinary team who's been working on it. Our 20th anniversary is next year. And so there's videos, there's information they can download. It's copdfoundation.org, copdfoundation.org. It'll take you to that. Um, there's just all sorts of things you could find. And let me also say, if you have bronchiectasis and
Yeah.
NTM, we've got a separate URL for that, so you could go right into that space. We have a lady on our team, and she's one of our patient advocates. Like me, she went to China to adopt a little girl in 2004. I came back with a little girl. She came back with a little girl and a chronic pulmonary disease, right?
Mm,
It can happen to
yeah.
anyone, right? And so now she and some of our other patient advocates, they host, I guess you'd call it a coffee club or a chat once a month. I learned so much by
Yeah.
listening, and now we're getting 80 to 100 patients per session listening in, asking questions, asking, can I use steam? What about this? Where do these bugs for NTM grow? Go ahead and win the Nobel Prize on that one. I'll come to Sweden to applaud for you, John. But NTM to me is a huge, huge mystery. I can't quite can't get my head wrapped around that at all. But patients talking to patients.
Yeah.
I don't know if it's caught off in Canada, but group visits to me this would be a great way to go with COPD because there's so much they all need to hear, right?
Patient
Whether it's
expert, and then
airway
hearing
clearance
it
or
from your
chronic
peer.
cough, and then you go, oh, this is how they handle it. Oh, this is what they do when they're in the grocery
Absolutely.
store. Oh, I could call Publix and have them put
Yeah.
it in the bin out front so I don't have to walk up and down all the aisles. I hadn't really thought about that yet.
But that's why rehab is so powerful, because people get into group either at distance or
Right.
in person, and obviously they learn from the expert, but they learn more from their peer because they hear someone that look exactly like them, out
Yeah.
of breath and so on, and oh, that person has been able to overcome. How did you do that? And then it
Right.
builds a social aspect, but also learning and trusting, obviously, people
Right.
like you. Okay, then this is
Right. And you
fantastic.
know what we're kind of missing in this story? I don't know if you have in Canada, but our missing puzzle piece is we have yet to have a famous person want to step up and
Yeah,
help lead this.
absolutely.
And you hate to say, but every disease needs it, right? Because every disease needs it. Maybe diabetes doesn't have a famous person, but
There is need a figure that everyone is going to listen, and then it's
yeah,
going to
Michael
matter.
J.
Yeah,
Fox, what he has done, what some other folks have done for
yeah,
mental health breakthrough, because it does give that inspiration. I'm old enough as a doctor, and my first work was in Atlanta, across from the CDC, when the AIDS advocates came forward, when the movie stars came forward, when the
yeah. Make a
athletes
difference.
came forward, when the patients with hemophilia came forward. That's why we have Ryan White
Yeah,
legislation, right? Because a mother came forward on behalf of her kid. I just got the goosebumps again. If we can have patients listening to this or family members, please come
yeah.
out, right? Please
And
come out and
we're too
talk.
old to be famous. Then we
Yes,
cannot play that role. Okay,
right,
that's the problem.
right.
Then let me ask you last, Gene. What is your last word? Okay, that you want everyone to hear. That would be really something that you feel that not only the patient but from all across. Okay, you want people to hear that. That could be something you have already said, but something that you feel that, okay, this is really what, okay, people have
Yeah.
to hear. This is really what we have to do.
I think it's the point that this could happen to you. You and I are
Hmm.
sitting here and we both have gray hair. And this is a disease that's often associated with aging. However, 47% of patients with COPD are still in the workforce. But it could happen to us, right? We could end up inhaling something. We could be in Hawaii thinking we're on vacation.
Yeah,
We could have been in 9/11. One of our kids could be in the military. None of us is above getting this disease, right? And I think as humans, we need to embrace that
yeah.
with compassion that somebody else walked a different path and they got it, you know, like I think of all of
Yeah.
our friends with Alpha 1, right? They just got it genetically and didn't.
Give importance to that disease and being respectful in people that have the disease. We could continue that for quite a long time. I really enjoy. Hopefully, people that are listening and enjoy that discussion. I guess we're gonna have to continue that in North Carolina, or better, you come to Montreal, Gene, and then
I'm
we
I'm all for
continue
that.
that in a good restaurant in Montreal, and you'd be very welcome. Thank you so
Thank
much
you.
for your
Thank
time,
you.
and great to the COPD Foundation, and continue the good work and everything
Thank
you
you.
are doing in the state and outside the boundary of the state. We want to collaborate with you. We want to get to be partner with you. we want to be with you. Please continue doing what you're doing. Thank you so much.
Oh, you made my day. You made my day. All right. Thanks so much.
I hope you enjoyed that discussion. And if you have any comment, any question, please reach to us. Thank you.
Thanks for listening to the Expand podcast. This is Season 3 on COPD. Stay tuned and listen to other episodes on chroniclungdiseases.com/podcast.